Welcome to the Sex Science Podcast, where we turn the latest peer-reviewed research on intimacy and sexuality into fun, accessible conversations. Generated by AI and fact-checked by experts, the Sex Science Podcast was created by LaShaw to empower you through knowledge. So, join us as we explore pleasure, relationships, human connection, and everything in between.
Hey everyone, welcome back for another deep dive. Today we're going to be looking at sexual health and contraception during menopause. I'm really interested to unpack all this, so let's get started.
Definitely. It's a topic that doesn't get enough attention, and this research article, Sexual Health and Contraception in the Menopause Journey, really digs deep into the nuances.
Okay, so right off the bat, they're talking about this whole biopsychosocial perspective on menopause. What does that actually mean?
So basically, it means looking at the whole picture when it comes to a woman's experience. You've got the biological changes, like the hormone shifts happening, but then there are the psychological factors and even social aspects that all play a role.
Okay, so it's not just like a purely physical thing.
Right, exactly. It's multifaceted. And this article really zeroes in on two conditions that affect a lot of women: genitourinary syndrome of menopause, or GSM, and then hypoactive sexual desire disorder, or HSDD.
Okay, wow, those are some acronyms. But seriously, what do those actually mean for women who are going through menopause?
Well, GSM is kind of like an umbrella term for a bunch of symptoms that can affect the urinary tract, sexual function, and even the genitals themselves. It can be things like dryness, burning, itching, pain during sex.
Oh, yeah, that sounds pretty uncomfortable. You know, one thing that really caught my eye in the article was they mentioned that you can have those GSM symptoms even if a doctor doesn't see any obvious signs of atrophy during an exam.
Right, and that's really important because it highlights why it's so important for women to actually talk to their doctors about what they're experiencing. You know, not just rely on what the doctor can visually see during a physical exam.
So what about HSDD? What's that all about?
So HSDD, it's basically a persistent lack of sexual interest or desire that causes a woman significant distress. And the interesting thing is it's not just hormonal, it's linked to neurotransmitters in the brain as well.
So it's complex, it's not just one thing.
Exactly. It's a complex interplay of different factors.
Got it. Okay, so if we're talking about GSM, how is that actually diagnosed?
Well, usually doctors will assess your symptoms, what you're describing, and also do a physical exam. But the article emphasizes how important it is to consider the woman's individual experience and distress. It's not just objective signs. And there are even some specific tools that doctors use to assess GSM. You might have heard of the Vaginal Health Index, VHI, and also the Vulvar Health Index, VHI. Those are all about getting a clearer picture of what's going on.
So both the objective measures and the subjective experience, that's interesting. And then, if someone is diagnosed with GSM, what kind of treatments are available?
Well, it really depends on how severe your symptoms are. For some women, if it's mild, non-hormonal options can be really helpful. Things like lubricants and moisturizers.
So those are good first steps anyone can try.
Right, exactly. But if those aren't enough, there are also prescription medications that can be really effective. Local estrogen therapy, sometimes called LET, is one option. There's also intravaginal progesterone and an oral medication called ospemifene.
It seems like there are a lot of choices.
There are. And that's a good thing. The article stresses that the treatment should always be tailored to the woman's individual needs and preferences.
Personalized care, so important. Okay, what about HSDD? You know, if someone is experiencing low desire, what are some of the things they can do?
Well, like with many things related to menopause, managing HSDD often involves a multi-pronged approach. First, you want to address any GSM symptoms because those can absolutely impact desire.
Right, that makes sense.
Hormone therapy can also be an option, particularly transdermal options or a medication called tibolone, which has some androgenic activity.
And what about testosterone? I know that's sometimes used for low desire in women.
Yeah, you're right. Transdermal testosterone can be an option. However, it's important to know that it's often prescribed off-label, meaning it's not specifically FDA approved for this use in women, and there are limited female-approved formulations right now.
Okay, interesting. So it sounds like there are options, but it's important to talk to your doctor about what's appropriate for you.
Exactly. Each woman's situation is unique.
Now, one thing that really surprised me in the article was this emphasis on contraception during perimenopause.
Yeah, that's a really important point.
I think a lot of people think, oh, perimenopause, I can't get pregnant. But that's not necessarily true.
No, not at all. Perimenopause is a transition, and it can be unpredictable. Hormones are fluctuating, periods can be irregular, and yeah, pregnancy is still possible.
So contraception is still very much on the table for women in perimenopause.
Absolutely. It should be part of the conversation with your gynecologist.
Wow. Okay. So what are we talking about in terms of contraceptive options? Are the same ones that are available to younger women?
Well, there aren't necessarily age restrictions on contraceptive choices, but certain health conditions can become more common as women get older, and those can factor into the decision. And it's important to remember that hormonal contraceptives have evolved and are actually much safer and more tolerable now, so they're often suitable for women over 40.
That's good to hear. So could you break down these hormonal contraceptive options a little bit more?
Sure, so you have two main categories. Combine hormonal contraceptives, or CHCs, and progestin-only contraceptives. CHCs contain both estrogen and progestin, and they come in forms that you've probably heard of, like the pill, the vaginal ring, the transdermal patch.
Okay, and the progestin-only contraceptives, those just have the progestin, right?
Exactly, and they have a really good safety profile, so that makes them a good option for women who might have some health concerns that would make CHCs not ideal.
Like, for example, if someone has a history of blood clots or migraines with aura, a progestin only might be safer.
That's a perfect example.
And within those two categories of hormonal contraceptives, are there even more choices?
Yeah. There are short-acting reversible contraceptives, like those pills, rings, and patches we talked about. Those need to be taken or applied more frequently. But then there are also long-acting reversible contraceptives, or LRRCs. Those include things like the hormonal IUD, which is sometimes called an intrauterine system, or IUS, and also implants. Those can last for several years.
Wow, that's a lot to think about. So how does someone even know where to begin?
Honestly, the best thing to do is to talk to your doctor. They can help you weigh the pros and cons of each option based on your medical history, your lifestyle, your preferences.
So personalized advice again, just like with those GSM and HSDD treatments.
Exactly. It's not a one-size-fits-all situation, especially at this stage of life.
Okay, now what about non-hormonal options? Are those still on the table for perimenopausal women?
Absolutely. Non-hormonal options like condoms, copper IUDs, sometimes called QIUDs, and permanent surgical sterilization are also possibilities. They're especially good choices for women who can't use hormonal methods or just prefer not to.
It's good that there's such a variety. And remember, the article mentioned something about extra contraceptive benefits. What do they mean by that?
Yeah, so that's one of the interesting things about some of these hormonal contraceptives. Besides preventing pregnancy, they can have all these other positive effects.
Like what?
Well, for instance, they can help regulate your menstrual cycles, manage heavy bleeding, reduce symptoms of endometriosis, and even protect against certain types of cancer.
So it's not just about preventing pregnancy.
Right. It can be about overall health and well-being.
That makes you wonder if using hormonal contraceptives during perimenopause might actually be beneficial in many ways.
It can be. And the good news is you can usually continue hormonal contraception safely until around age 55, which is when most women have gone through menopause completely.
But what if you want to stop before age 55? How do you know it's safe?
Again, talk to your doctor. They might suggest checking your FSH levels, which is a hormone that can tell us where you are in the menopausal transition.
So personalized advice is key. Always.
Absolutely. Menopause is a unique journey for every woman, and having that open communication with your healthcare provider is so important.
So we've talked a lot about the physical side of things, like how menopause can affect a woman's sexual experience. But what about the emotional and relationship side of it all? I feel like that often gets overlooked.
Yeah, you're absolutely right. I mean, menopause isn't just a physical transition. It's an emotional one as well. And all those changes, both in your body and your mind, they can definitely affect your relationships.
I can imagine. Like if you're dealing with uncomfortable GSM symptoms, I mean, that's got to have an impact on, intimacy with your partner.
For sure, it can. Physical discomfort can make sex painful or even impossible, which can then lead to, feelings of frustration, anxiety, maybe even resentment in the relationship. And it's important to remember that both partners are kind of going through this transition together.
So open communication is key.
Absolutely, yeah. Talking about what you're experiencing, both physically and emotionally, can make a huge difference. And it's not just about talking to your partner, it's also about seeking support from, your healthcare provider, therapists, support groups.
So having that support system around you.
Yeah, exactly. And remember, every woman's experience of menopause is different, right? There's no one-size-fits-all solution. So it's about finding what works for you and your individual needs.
That makes total sense. Now let's go back to something we touched on a bit earlier, which is contraception during perimenopause. The article really stressed how important that is, but I'm curious, What are the risks associated with unintended pregnancy during this time?
That's a great question. As women get older, the risks associated with pregnancy do increase. We see higher rates of complications like gestational diabetes, preeclampsia, even premature birth. And unfortunately, unintended pregnancies during perimenopause often end in miscarriage or elective abortion.
Wow, so that's a lot to think about. It's not just about preventing the pregnancy itself, it's about protecting your health, too.
Exactly. And luckily, there are so many safe and effective contraceptive options available now, no matter how old you are. Every menopause journey is unique, so having a supportive healthcare provider to guide you through it is really important.
So we've covered a lot in this deep dive about, sexual health and contraception during menopause, and it's clear that it's a time of, big changes. But it doesn't have to mean the end of a fulfilling sex life, right?
Oh, absolutely not. It's more about adapting and kind of understanding what's going on in your body. And this research really drives home the point that it's not a one-size-fits-all experience.
Yeah, and I think it's so important for women to, feel empowered to advocate for their own needs and preferences during this time.
I completely agree. And that starts with open communication, both with your partner and with your healthcare provider.
And speaking of healthcare providers, this article actually calls for more research into women's experiences with menopause, especially when it comes to personalized care.
Yes. That's something I'm really passionate about. We need more studies looking at how effective different treatment options are and how we can really tailor them to individual needs.
So we've got the physical changes, the emotional aspects, the relationship dynamics, the contraception considerations. I mean, it's a lot.
It is, but knowledge is power. And what I really hope you take away from this deep dive is just a sense of empowerment, that you have options and you deserve to feel good in your body and in your relationships, throughout menopause and beyond.
That's a great message to end on. So for all of you listening, what stood out to you most from this conversation. What are your priorities when it comes to sexual health during menopause? Maybe it's time to have a conversation with your doctor or even just with your partner.
Yeah, it's never too late to start prioritizing your well-being. And remember, there's a whole community of women out there who are going through similar experiences. You're not alone.
Thanks for joining us on this deep dive into menopause. We'll see you next time for another fascinating exploration of the world around us.
Thank you for listening to the Sex Science Podcast brought to you by LaShaw. We hope that you learned something new about the wonderful world of human intimacy and sexuality, and join us next time as we dive into more fascinating research. And remember, science is for you. Music for this podcast was produced by SOUNDRAW.